Hello, everyone, and thank you so much for being with us today for the Compassion in Politics annual conference. And this year we are delighted and honoured to be co-hosting it with Professor Michael Marmot and drawing on the theme of his groundbreaking report, Build Back Fairer. Through a series of panels, we're going to be asking many experts, as you see, it's going to be quite a tight schedule, many experts the question, how do we build back fairer after COVID? A few bits of housekeeping just before we begin. Please post any questions that you have for our panelists in the Q&A section at the bottom of your screens. We won't be using the raised hands function today just because of the timing, that can delay us slightly. So do put all your questions in the Q&A, but the chat function as well should be open. So if you do want to just post comments or links to anything for a general conversation, you can do that there. If you need to leave at any time and rejoin, you should be able to do that through the link that you've been sent. If not, drop us an email, info@Compassion in Politics, and we should be able to still pick it up. As I said, timing is very tight, so we may just have to sort of bluntly cut off speakers or the panels to keep things moving. So apologies in advance to everyone for that, but hopefully that will just keep us to time. And do tweet throughout using the hashtag #BuildBackFairer and tagging Compassion in Politics, and we will try to retweet and keep the conversation going online there. So, as I say, series of panels today, 4 different panels, all addressing the same question, but from slightly different angles. And starting us off, we have our first panel, which is on building back fairer in health. And I am delighted to introduce Professor Michael Marmot. Michael is Professor of Epidemiology and Public Health at University College London, Director of the UCL Institute of Health Equity, and author of the Build Back Fairer report. So over to you, Michael, for your first pitch.
Thank you. Although I'm billed as speaking in the health session, the other sessions are all absolutely crucial for health. Fair politics, fair economics, fairer society, all relate. And to get fairer health, we need greater fairness in each of these domains. At the beginning of the pandemic, I, like most other people on the planet, went back and reread Camus' The Plague. And you may remember words to the effect of, Camus said, "The pestilence is at once blight and revelation. It brings the hidden truth of a corrupt world to the surface." Now, that's strong language. I didn't talk about a corrupt world, although given what's happened in the UK, I might well have talked about a corrupt world. But what I did say was that the pandemic would expose the underlying inequalities in society and amplify them. And so it's proved, both with the effect of COVID-19 following the social gradient, exposing racial and ethnic differences, and the effect of the societal response. To talk about health for a moment, I've just reviewed Michael Lewis's book on the pandemic in the US, and he documents the catastrophic failure of political leadership, but also public health leadership. The CDC failed miserably to provide leadership and to provide the technical infrastructure. In this country, we had the public health resources. We do have a public health system, unlike the United States, and we crippled it. We crippled it. We abolished Public Health England in the middle of a pandemic. We had cut its funding by 40% before the pandemic. We stripped £800 million out of local public health. And then we said, oh, we haven't got the capacity. We better privatize tracing and testing and the like. So we had a public health system, unlike the United States, and we chose not to use it. And what the vaccines show, which are the signal success of the pandemic, is what public investment can do. CEPI invested $1 billion in vaccine development, unlike what one prominent politicians said, the success of the vaccine does not demonstrate the power of greed. It demonstrates what the public sector can do and the vital importance of public investment. As Michael Lewis says in his US book, the market system completely failed when it came to developing the vaccine. So to come back, as I said, if we're going to build back fairer, it's politics, it's society, it's economics we need. And I have 6 domains of recommendations in my Build Back Fairer report, which relate to the recommendations in 2010. Give every child the best start in life, education and lifelong learning, employment and working conditions. Everybody should have at least the minimum income necessary for a healthy life, healthy and sustainable places in which to live and work, and taking a social determinants approach to prevention. And to achieve that, we've got to put equity of health and well-being at the heart of all government policy. Thank you.
Thank you very much, Michael, and thank you in particular for compressing all of the amazing research you've done into such a short space. We're now going to hand over to Professor Dawn Edge. Dawn is Professor of Mental Health and Inclusivity at the University of Manchester. Dawn.
Thank you. Thank you so much for the invitation, and I'm delighted to be here. So the question I wanted to address is, what did the experience of the pandemic teach us about inequality in Britain? And I think in actual fact, it's taught us how little we understand. And also, it really should make us question why so little action about the things that we do understand has been taken to tackle the well-known inequalities in health that have been around for generations, especially given that the NHS, the welfare state, indeed was formulated to eradicate such inequalities. So in the work that I do, which is specifically around mental health, and thinking about it from an ethnicity perspective, we've known for decades that Black people in the UK are 6 to 9 times more likely to be diagnosed with psychosis, but not in their current country of origin. We know that those people, once diagnosed, are much more likely to come into mental health systems through what are called negative care pathways, so much more likely to be sectioned under the Mental Health Act, much more likely to have police involvement versus their GP, and that in services they're more likely to die through control and restraint, they're more likely to be secluded, more likely to be given psychotropic medication, and much less likely to be offered psychological therapies. And it's not just for mental health. In terms of physical health, we know that if you're of Black Caribbean origin in the UK, your health is comparable to a white British person 10 years older than you. And that if you're Caribbean, Pakistani, or Bangladeshi origin, you will live around 6 to 9 years, 6 to 9 years fewer good health or disability-free health years compared with your white British peers. And many of us will have seen, some of us have known for some time, but many people have now realized that if you're a Black woman, you're 4 times more likely to die in childbirth than the white British woman. And importantly, that doesn't take into account all the near misses about which there is relatively little data. And again, some of you might have seen in 2019 that a 21-year-old called Evan Smith died from sepsis and multiple organ failure in hospital after calling 999 to try to get help because he wasn't being treated. He was literally dying. And the coroner's report pointed to the lack of understanding of sickle cell disease, a condition that's predominantly experienced by Black people, by the medical and nursing staff. So this young man died of a completely preventable death in an NHS facility because the staff who were there were not actually trained to recognize and to treat his condition. So thinking about what needs to change going forward, I know obviously there's going to be huge constraints, financial constraints, but I don't think this is a money issue. Money really matters, as Michael has said. You can't continue to strip the healthcare system of investment and think it's going to continue to manage when our healthcare needs are rising exponentially. But it does beg the question about why we continue to pursue kind of one-size-fits-all model of care that doesn't really acknowledge diversity. And I think that's where we need to think differently and think smarter if we are going to build back fairer. So just an example, why did it take until 2020 for a Black medical student, Maloney Mukwende, to author a book that shows how different skin conditions appear on Black and brown skins? And that's including things that, life-threatening conditions. So that takes me back to the question about our training. How are we preparing people to actually deliver good quality healthcare that provides equitable healthcare for everybody? And from the work that I do, obviously I'm an academic, so just thinking also about the research, I think we really need a fundamental rethink about what counts as evidence and how we collect that evidence that underpins the healthcare that we receive. So for example, I consistently review research grant applications where the exclusion criteria include things like inability to read and write well. Well, we know that people who've been through the care system or in the prison system are often much less likely to be literate than the rest of the population. And similarly, it will often exclude people.
Okay, so wonderful. So we're now going to hand over to Debbie Abrahams, MP. Debbie is the Labour MP for Oldham East and Saddleworth and co-chair of the All-Party Group for Compassionate Politics, a fellow of the Faculty of Public Health and former chair of Labour Party's Health Committee, so has a considerable grounding in health and public health. So over to you, Debbie.
Thank you. Thanks so much, Matt. And I think I should just start by saying I agree with everything that Michael and Dawn have said. One of the reasons I became an MP was because of the field of work that I was working in as a public health academic, and that was health inequalities. And since I've been an MP, I've been trying very hard as an opposition MP to ensure that we do try and consider what the impacts of national policy are. So in addition to chairing the all-party group for Compassionate Politics, we also have an APPG for health in all policies. And that has tried to look at, from both a prospective and a retrospective view, what the impacts of those policies would be on different populations. So hopefully some people may feel inclined to go and have a look at these reports, the latest one of which was published earlier this year. And the focus of the two that we have undertaken has been on social security and the impacts, for example, of the 2016 Welfare Reform and Work Act. One of the issues that has been put to us is that there are no methods, no procedures, no tools that can enable governments to undertake these sort of assessments. And I'm afraid that's absolute nonsense. And we've shown very clearly by the retrospective and then the prospective work that we can accurately assess the wider impacts on health of these policies. And in some areas, for example, air quality, we will be able to quantify the impacts on physical health in particular. In relation to that, I put together some new clauses for both the Finance Bill and the Environment Bill, and that was to look at both the impacts on socioeconomic groups, but also on those groups with protected characteristics under the 2010 Equality Act. And we also wanted to look at the points that Dawn was mentioning just now about not just the impact on life expectancy, but healthy life expectancy as well. And immensely disappointing that the government, given their supposed commitment to levelling up, didn't take on board any of these new clauses. As Michael said, it's absolutely right. Health is an outcome of all the other panels that are going to be being discussed later today. We must bear that in mind, and I will certainly be looking forward to reading that. But I'm confident that, as we progress with a new policy platform, and I have to speak as a Labour MP, that we need to address that, and we need to address the structural inequalities that Michael and others have been advocating and their impact. And we have to have population health and wellbeing at the heart of all that we do, not as a byproduct, but as a heart of all that we do. And this means, in addition to addressing inequalities in income and wealth, we also need to reflect on and tackle the inequalities in power in our country. And this is so much about the work that the APPG for Compassionate Politics has been working on, about the shift in the culture of politics, so one that is more cooperative and more compassionate. And Michael has mentioned in his COVID review about the divisiveness of politics and how that has led to societal divisions, an increase in racism, anti-Semitism, Islamophobia and hate crime in general. And it's easy to see why Take Back Control resonated with so many people when such a fundamental psychological need has been overlooked. So this is why addressing these power inequalities through our political system, for example, through citizens' assembly, but also I'd say through electoral reform, is absolutely essential. But we need to go beyond this to tackling inequalities in everyday power. So how frustrating is it? You can just imagine you've been put on hold when you're ringing up about a leak in your house and water running down your walls, or repeatedly having to report fly tipping where there's vermin and they're coming into your house, or having your car or vandalized or burgled and no police being available to come and deal with it. How frustrating is that? We must get better at not just what we do, but how we do it. Process does matter. Very quickly, finally, putting together a hopeful message, I just want to mention a couple of things we can do, even with a government that may say one thing, but actually does another. And that's we set up in Oldham an Oldham Fairness Commission, bringing together private, voluntary and public sector organisations, as well as communities. And we were the first borough in Oldham to set up a real living wage, and that's rolled out across Greater Manchester as part of one of the recommendations from the Independent Inequalities Commission. So you can do things even when there may not be a government that's behind you. Thanks so much.
Wonderful. Thank you, Debbie. And we're going to very quickly now roll on to Dr. Rachel Clarke. Rachel is a palliative care doctor and author of Your Life in My Hands, which was her memoirs of life as a junior doctor, and also Dear Life, Breathtaking. Rachel.
Thank you very much. And I will be brief, so we've got time for questions. But I'd just like to make a couple of observations based on the last 16 months or so that I have spent on the front lines. I spent some of that time on COVID wards, treating COVID patients. So had a real sort of on the ground view of, I would suggest, the fairness or lack of fairness with which different groups in British society were treated as the pandemic unfolded. And my first observation is I think a really important one, because if we're thinking about how to do things differently in the future, we surely have to recognise that a more equal, a fairer society has to be one in which people are genuinely valued equally. We put equal value on a human life, whatever their age, race, health, etc. And that was very much the rhetoric in March last year. You know, we're in this together, we'll get through it together, and we will absolutely protect Britain's most vulnerable members, and we will throw that protective ring around them. And of course, working on the front line as I was, we saw the exact opposite unfold, that there was a lot of rhetoric about protecting vulnerable people, and there was precious little in the way of action. The whole thrust of activity was about saving people in intensive care, ventilators, and the vast majority of the over 150,000 people who've died of COVID in Britain are, of course, not people who ever went near an intensive care unit because they were too frail, too elderly, too unwell to ever stand a chance of benefiting from that treatment. So the vast majority of people who died were too vulnerable to benefit from what filled all the newspaper headlines, all the political rhetoric, and actually left behind were the people I cared for over and over and over again on my wards in the hospital: elderly people, people from care homes, people who were too frail and fragile, and I would suggest voiceless, lacking a power or a status or a voice in society to be heard. We know they were abandoned in care homes as well. We know that whole swathes of the population, their lives simply were not valued as equal to the people who were deemed worth saving. And whatever you think about the politics of herd immunity and whatever's now said about it, it was very palpable this time a year ago that somehow we had two tiers of people in British society, those who were worth saving and protecting, and those who are expendable because, sorry, you've had a good innings and it's time for you to go. And I want to make the case as strongly as possible that if we are to learn from this experience, in Camus' words, if we're to seize upon what is revelatory, it is that horrible, horrible fact that division between the two tiers of society, those we save, those we cast to the wolves. We need to do this better, and surely that's something all our politicians can agree on.
Thank you, Rachel. Extremely powerful. Thank you. So we do have time for questions. So we already have one in the Q&A, but anyone else would like to pitch in, please do type them out in the Q&A for us. So this one is from Alex, who has asked, and I think probably everyone on the panel might, I think we have time for everyone to issue their comment. What would putting health at the centre of government policy look like? So we might as well go in the same order we just came through. So if Michael, you want to start and give Rachel time to have a drink and get ready for answering that question.
Yeah, so let me give you two examples of what it would look like. You would not have a chancellor stand up and say, the number one priority is to save money. Some mythical notion of the debt to GDP ratio that will be good or bad. You would say the number one priority is to improve the health and well-being of the population in the most equitable way possible. And arguably what happened in the decade from 2010 on, as I documented, where health stopped improving, inequalities got bigger, and health for the poorest people outside London got worse. Arguably, that was the result of the Chancellor standing up and saying, our number one priority is to spend less money, and we'll do it in as regressive a way as we possibly can. If you put equity of health and well-being at the heart of all government policy, you would never do that. Second, what are we going to do about levelling up? Build railway lines, bridges, tunnels, or investing in early child development, in better education, in adult social care, which would be better in terms of equity of health and well-being. So that's what it would mean, putting equity of health and well-being at the heart of all government policy. You would look at proposed expenditure and you say, which would benefit the population in the most equitable way? And I know the answer. It wouldn't be building tunnels and bridges.
Thank you, Michael. Dawn.
Yeah, so totally agree. And I think it is about taking a life course approach. So, you know, we know that if you look after pregnant women, their babies do better, and they do better as they grow up. They have better educational outcomes. So, you know, for a relatively small investment at one end, you actually gain at the other end. So I don't think it's just, you know, the idea that you throw money at things or you take money back. It's not really thinking about the sim around. And so I think also recognizing that those people who have the worst health in childhood, it persists across the life course. So they're also going to need more care at the other end. So the healthier your population are as children and as young people, and the better educated they are, so they can take advantage of self-care because they're more literate and more able to embrace their own healthcare, then actually you're going to save money. It's a bit of a no-brainer to me, really, that the amount of money you invest upstream is going to pay dividends at the other end. So I think we just need to think differently.
Thanks, Dawn. Debbie.
Yes, I agree with everything that, again, that's been said. I mean, you would want to start with a policy platform that does recognise where we are. As Michael has said, that our life expectancy has been flatlining, healthy life expectancy is as well. Areas with the poorest health, such as mine here in Oldham, have experienced even worse, disproportionately experienced the worst health. And you'd want to make sure that your public spending, your investment, and your tax arrangements recognise this, so that there is true levelling up. And for a politician, I'm going to be very brief, and that's it. Thank you.
Thank you, Debbie. Rachel, well, before we come to you, there's a couple of questions actually that have just come through, which is, I think, mainly directed at you. One is simply, how has it felt in the NHS during the pandemic, and has it changed your view of the health service? And then there's another question about, of course, everyone should be treated and valued equally, but when the resources are stretched, how do we make those difficult decisions? We've had to battle with this for a long time. So I don't know if you can pick and choose what you feel best able to answer, perhaps, Rachel, but over to you.
Well, on how it feels, in some ways, I felt very lucky throughout to have an actual job to do where I felt like I could help, you know, and actually roll up my sleeves and do something useful. I know a lot of people felt so frustrated and impotent that they were locked down at home and couldn't do something. And I think also, and this gives me cause for great optimism moving forwards, literally every single day at work in the NHS, I saw staff, patients and family members almost unanimously behaving with such astonishing strength and dignity and courage and kindness, more than you could ever believe. So I sort of had this daily dose of the very, very best of humanity. And when you see that, it's real, and that's an incredible counterbalance to all the things that might make you feel cynical. In terms of figuring out how to allocate resources, that is, of course, a really difficult question, and it's one that we have a very effective national body in place, the National Institute for Health and Care Excellence, precisely to allocate resources according to clinical and cost effectiveness. So that's a way of doing it to equitably, openly and fairly, so that everybody can be on board and trust that process. The way not to do it is to talk the talk, the rhetoric about protecting the most vulnerable, while patently, obviously, doing the exact opposite and throwing vulnerable people to the wolves, which is what I experienced. And that's precisely what you don't do moving forwards.
Thank you, Rachel. And I'm just going to check, do we have a final? Someone, Nicola has said that she's put in this comment here that she, obviously wonderful contributions from the speakers, goes without saying, but she's disheartened by what she feels is the opposition, ideological opposition to the policy ideas from the government. How do we go forward if the government has no intention of levelling up? I'm going to, as we've got a minute left, I might just give that one to Debbie, if that is okay, and then we will move on to our next panel. So you've got, I think, about 45 seconds, Debbie. Okay,
so very, very briefly, it reflects some of the things that I said in my opening remarks. So you need to continually put pressure on the government to recognise that if they are committed to levelling up, this is what they need to do. If they're completely refusing, then it stands on the record that they're refusing to acknowledge this. Michael is absolutely right in terms of the investment in infrastructure is not the way to go if you're serious about levelling up across society. But finally, I mentioned, just to give a bit of hope at the end, there is stuff that you can do locally. So get those people, your activists locally. The same way I know that Kate's going to come on and talk about, hopefully, the Greater Manchester Inequality Strategy. That is making a real difference. And I'd just like to say that Oldham did it first. Thank you.